Hello and welcome to Health Live at Seniors Today. We are delighted to have here with us once again Dr. Rajiva Gupta, who is Senior Consultant, Diabetes and Internal Medicine. Dr. Gupta, as we've met here in the past, did his MBBS from the Maulana Azad Medical College in New Delhi and his MD from the Ram Manohar Lohia Hospital in New Delhi. He has done his postgraduate diploma in diabetology from the Johns Hopkins University School of Medicine and a specialist certificate course from the International School of Medicine or International School of Diabetes. Dr. Gupta is, as I mentioned, is currently in Delhi and in Delhi NCR at his personal clinic Upchar Wellness in Gurugram, as well as attached with the CK Birla hospitals at Gurugram and Punjabi Bagh in New Delhi. He has been practicing earlier at his clinic in Ashok Vihar in Delhi and has been affiliated with major hospitals like Fortis, Max, and the Lung Institute. Dr. Gupta has conducted continuing medical education programs in the field of internal medicine with a special focus on diabetes, clinical cardiology, and geriatrics, and given lectures and conducted certificate courses on various topics like diabetology, cardiology, critical care, geriatrics, and COVID-19. He has spoken at various seminars and he has been an active researcher. We are delighted to have you with us once again, Dr. Gupta. Dr. Gupta is going to be speaking about an important topic for seniors, and not just for seniors, but for people who have medicines. It's on medication overload and the impact of polypharmacy on seniors. Dr. Gupta, welcome to Health Live at Seniors Today once again. How have you been?
Yeah, thank you, Pradhiman. So, in a day-to-day practice, we find many patients who said, "Doctor, बहुत सारी दवाइयाँ हैं, कम कर दो." So initially, many years back, I used to think, why should the medicines be reduced? After all, the medicines are being given for the benefit of the patient.
Absolutely, doctor. So what I'm going to do is I'm going to just intervene right now. Doctor, there's a bit of a technical hitch, so doctor doesn't have a presentation here, but he will be speaking. Those of you who have questions, please put them in the Q&A tab. After around 10 to 15 minutes, when after doctors finishes speaking, we will get to your questions and answers immediately after that. Please mention your age and your gender as always. Over to you, doctor.
Thank you. So I used to wonder as to why people are asking to withdraw the medicines or stop the medicines or decrease the medicines, because we always thought that the medicines are given for the benefit of the patient. But then over the years, we also observed that somewhere, despite medicines, the condition of the patient is not good, the quality of life is not good. And then on an empirical basis, thought of removing certain medicines or decreasing the dose, and surprisingly, the quality of life improved significantly. So this way, the concept of polypharmacy and its adverse effect on the people, especially the senior people, emerged. So let me take one case scenario. Case scenario one: doctor, he's a PhD by education. Dr. BD, 93 years old. He retired as a professor from a university. He's an active academician and an author. He has a past history of diabetes, hypertension, chronic kidney disease. And currently he is on 3 medications: insulin, which is given 3 times, 2 medicines for diabetes, 2 for hypertension, 2 for kidney disease, and totally 8 medicines. And recently, about 2 months back, he was diagnosed with a tumor in the brain. So apart from the standard treatment of the tumor, he was also advised an anti-epileptic drug for prevention of seizures. So what happens is that it has become a norm almost. If any brain problem is there, there is a tendency to prescribe anti-epileptic or anti-seizure medication with the aim of preventing seizures. However, as evidence says that people who have not had a convulsion or a seizure, they should not be given preventive anti-epileptic medication. So now it becomes very difficult to challenge the doctor's opinion and the suggestion. So the patient's attendants, they agreed for that and started giving him anti-epileptic medication in addition to the other treatment. And see, sir, the outcome was the patient started having imbalance, tending to fall, became incoherent, drowsiness. So his daughter, who said that I can't see my dad like this. He's so fond of writing, so talking, and what it has become. Then she called me up, and then we also did a research, and she also did, very educated people. They did a research, and they said no, not nothing doing. We're not going to give him this medicine. Another scenario, and the medicine was stopped, and he improved. Another scenario, DR 75 years old male. He has multiple problems: heart failure, chronic obstructive pulmonary disease, and mild cognitive impairment. So he wants to see the drugs, furosemide or Lasix for fluid retention, metoprolol or Betalog for heart failure, salbutamol inhaler or levosalbutamol for COPD, donepezil for cognitive impairment, aspirin because he's having a heart problem, and ibuprofen or brufen as needed for joint pains. Unfortunately, he experienced severe GI or stomach bleeding and was rushed to the hospital. So what has happened is the combination of his medications, including aspirin and ibuprofen, has led to the bleeding. The kidney function has worsened due to cumulative effects of multiple medications, which are metabolized through the kidneys and which further aggravated the bleeding tendency. Now, patients who are having chronic kidney disease, in them the bleeding tendency tends to rise. So, both cases demonstrate how polypharmacy, that is, use of multiple drugs, has posed significant challenges and harms for both the patients. Multiple medications have been given. They have led to interactions within themselves as well as on the disease, adverse effects, complications, and not to say compromised the quality of life. So these cases highlight the hazards of polypharmacy and a reminder to ensure that it is our duty to take care of safety as well as the well-being of our senior people. So safe and effective drug therapy is an essential part of caring for the seniors. What has to be done is a medication list, an up-to-date medication list that includes all the medicines, that is over-the-counter medication should be accessible to all healthcare providers in the medical record. This enables identification of the drug-related causes of new symptoms, eliminates inappropriate duplication of the medicines. For example, one consultant, the patient is being shown to multiple consultants, one consultant writes medication and another one writes the medicines from the same class of drugs. Allows reviews for the interactions and allows streamlining of regimen to improve adherence. Then there should be an annual drug review. And that annual drug is, as a standard, but it depends upon the condition of the patient. And all adults should have the drug regimen review. It allows an opportunity for discontinuing unnecessary medications or addition of necessary drugs that are not currently prescribed. Drug indication: all drugs prescribed for seniors should have a clearly defined indication. Now, not that something is not harmful, it should be given, because we don't know, apart from the obvious harm, there will be interaction with the other drugs. So if there is no indication, clear-cut reason for prescribing the drug, such a drug should not be prescribed. And it allows discontinuing medications that have been prescribed for unclear or transient indications. All patients should receive appropriate education about the use of any prescribed drug. For example, there is a drug which is called SGLT2 inhibitors, which are used in the treatment of diabetes. These drugs, if they are used in elderly, they may cause a little bit of hypotension, low blood pressure, fluid loss, tendency to dizziness, fall. So this thing should be warned and the patient should be educated about them to ensure good amount of liquid intake and take care of this thing. Education may improve adherence and clinical outcomes, also can alert patients or the caregivers to potential adverse effects. At the same time, if you are giving a medication, we should also monitor the response to therapy. The response to therapy should be documented for all ongoing medical conditions. Documenting response will help clarify whether a drug is meeting the therapeutic goal or in which it was prescribed and provides the basis for continuation, modification, or discontinuation. Now, indefinitely giving medication which are not showing any benefit is definitely not worthwhile and it poses more problems for the patient. So polypharmacy in the elderly, which is our topic for today, is defined as a concurrent use of multiple medications, usually 5 or more. So that is what a working definition is. And if we revise or consider what are all different types of medications which are used by all, especially the elderly, the ones which are prescribed, which are part of a prescription, over-the-counter medications. Over-the-counter medications may be some sort of supplements or a vitamin, or maybe a medicine for a laxative or a laxative. Herbals and supplements. For example, people are many people take ginseng, zincuba, biloba extract and glucosamine for arthritis. The seniors are at increased risk for polypharmacy. And why? What are the reasons for that? Will come shortly. The usage pattern of prescription medicines in a survey in the US revealed that at least 57% of people are taking 5 or more medications, and 20% are taking 10 or more. About 38% are taking the over-the-counter drugs. Herbal medicines are consumed by 63% of people. And when a patient is discharged from a hospital, he is on an average around 14 medications which he has to take after discharge from the hospital. So see, the magnitude of usage of polypharmacy is so high in the elderly. And polypharmacy is the strongest risk factor for medication related problems. It is not the side effect. Side effects may be there, but side effects are pretty obvious. And usually the physicians mention those side effects to the patient. But the side effects are tested in isolation, as will come later on. The use of multiple drugs concurrently, that is a cause for concern. The risks of polypharmacy are many, and a statement was given as a policy statement by the American Medical Association: reduce polypharmacy because it is a significant contributor to seniors' morbidity. And a physician by the name of Louisville, USA-based Tom James III, MD, championed this new paradigm: reduce polypharmacy, and you will decrease the morbidity of our senior population. There is an inverse relationship between the number of prescriptions the patient takes and their longevity. While all drugs are tested individually for their side effects, they are not tested in combination. So this is what I was mentioning earlier. In medical school, doctors receive training for adding medication, not for subtracting them. And this is so true. When we were studying pharmacology or even medicine, so they were never said that you stop that medicine. Okay, the patient comes with he's on aspirin and he's having burning in the stomach, so let him give him some sort of a ranitidine or something. Starting a medication is familiar. It has been there ever since and considered a positive action, because somewhere if you give a medication, it indicates that doing something to help the patient. While removing a medicine is less familiar and may be considered lower priority or a withdrawing care. Now, many times patients come in the clinics, we examine them and then we find that there is no requirement of medication. They are doing pretty well. Their quality of life is good. Their parameters are good. So probably they do not require that many number of medications, or probably no medication at all. Just the lifestyle modification or the lifestyle adherence would suffice. The risks of polypharmacy are increased in the elderly because of the metabolic changes, which are age related, especially the drug clearance by the kidneys with aging. And this risk is compounded by the increasing number of drugs used, because if you are using a particular, there is an age related decline in certain functions, and if you are using a drug which is itself toxic, for example, to the kidneys, then the adverse effects would be compounded. Prescription of potentially inappropriate medication. For example, the usage of long-term PPI like pantoprazole, rabiprazole, or omeprazole types of medicines. They may not be an indication, but they are still prescribed. Or host of multivitamins. If somebody has got an arthritis of the knee, the essential treatment is physiotherapy or exercise, strengthening of the quadriceps, and maybe if it is extremely severe and there is a mutual agreement between the doctor and the patient, for an arthroplasty. So such patients, if they are given multiple types of medicines, they're probably not going to make any alteration in the quality of life of the patient. Then there is an increased possibility of prescription cascade. So this is a phenomenon which has been appreciated recently. where the process whereby the side effects of drugs are misdiagnosed as symptoms of another medical event and lead to additional prescription. We'll come shortly on a few examples of this prescription cascade. So polypharmacy, long-term use of multiple medications increases the risk for adverse health outcomes such as falls and hospitalization. And they have been estimated as if a person is on 2 medications, the chances of such adverse events are around 13%. If on 5 medications, the chances are around 58%. And if the person is on more than 7 medications, then the chances are as high as 82%. Now it's I mean scandalous. 7 medications, the chances of falls and hospitalization because of the polypharmacy becomes so high. Then there is a negative impact on the health-related quality of life, that is self-perceived physical, mental, and social functioning. That is what is health-related quality of life. There is an increased risk of adverse drug events like falls and consequent fracture. And if the patient falls, it is not just the fall, the patient becomes dizzy and falls. It is the consequences. The patient, suppose unfortunately the patient develops a fracture of the hip, then surgery, then immobilization, and the consequences and the harmful effects of immobilization. It's a whole cascade of adverse effects which probably gets rooted into the adverse effect of that particular drug. Cognitive impairment. Many people they are put on, we find many people they put on different types of antidepressants or anti-anxiety agents, and the attendants tell us that the patient become confused, chakkar aate hain, bhool jate hain, difficulty in concentration. Medication errors, the more the medications, there may be a confusion in the dosing and there may be errors. Drug interactions that we have already discussed. Increased risk of hospital admission, almost more than 100,000 per year in the USA. Failure and delay in diagnosis of a new symptom. For example, if the patient is on multiple medications, he develops a rash. Now it's so difficult to find out what is the culprit, which medication to stop. The more the number of medications, the more the problem with the adherence. With a complex medication regimen, it can become difficult to keep track of which medication to take, when to take, leading to missed doses. The patient may miss the doses, or it may be taken incorrectly. If something is given 3 times a day, he may miss out on a particular time. So which will lead to reduction in the overall effectiveness of the treatment plan. And obviously, the more the number of medicines, then the cost of treatment also increases due to purchase of drugs, need for more frequent doctor visits, monitoring, laboratory tests, and maybe the complications of that multiple drug usage. It again further adds to the cost of the treatment. So we've talked about the scenario of drug use in the elderly, why there are so many multiple the side effects occur, what are the risks for polypharmacy. So why is polypharmacy so high in the elderly people? It is primarily because of the rising prevalence of chronic diseases. Chronic diseases are one which are long lasting and which require a continuous monitoring and care, which leads to the prescription of several medications to address each condition. If your patient is hypertension and diabetes, so there would be medicines of high blood pressure as well as medications to treat diabetes. Multimorbidity. So multimorbidity it's a fallout of the previous statement of mine. Multiple chronic conditions at the same time, usually 2 or more. For example, heart disease, high blood pressure, high cholesterol, arthritis, chronic lung disease, diabetes, thyroid disorders, chronic kidney disease, prostate ailments, depression, chronic anxiety, neurological disorders like Parkinson's disease, cognitive impairment or dementia. And it has been, surveys tell us that 20% of people have 5 or more chronic conditions. The risk of drug disease interactions, it increases significantly. So medications for one condition adversely affect a concurrent condition, which also increases substantially. We'll come to a few examples shortly. Then, so chronic disease rising, multimorbidity in the same patient, multiple caregivers. So a patient may be visiting an endocrinologist or a diabetologist, as well as visiting a kidney specialist and a cardiologist. Each one would write their own medications, and unfortunately, one consultant doesn't see the medications of the other, neither tells them to stop those medicines. there is no review of medications, and many times this leads to complicated regimens, multiple drugs, and even duplication of the drugs. Prescribing cascades, as we mentioned earlier, plethora of clinical practice guidelines. So there are so many guidelines. Now, guidelines would say, some guidelines would say use this medicine, some use this medicine, and the result is that the number of medicines increased. Symptom management. So elderly may, apart from the basic medical problems or the illnesses, there may be symptoms which require different medication. For example, a person may be having chronic pain. So he's prescribed a painkiller. There may be depression, antidepressant, sleep issues. There may be sleeping aids or the sleeping inducing agents. So all these symptoms, to control symptomatic treatment, the patients are given these drugs, and probably instructions are not given to stop. Instructions are not given to guide them as to when to stop them. And apart from the basic essential medicines, these also medicines get added up to the list, and the people keep on taking them. Preventive care. Some medications are prescribed to prevent potential health issues or complications. This can be commoner in older adults, where medications are used to reduce the risk of, for example, heart disease. So heart disease, aspirin may be given, or a statin, aspirin for blood thinner, or statin for lowering cholesterol. For osteoporosis, they may be given certain medications. And so just to prevent. Now, in these cases, we have to see whether that preventative therapy is really justified, where there is enough evidence to support the use. What is the clinical scenario of the patient? What's the age? What's the longevity? What are the current medical conditions which the patient is having? And many times patient requests are there. They say, we have heard this from somebody or from the internet, and please prescribe this medicine to me. This is very good. So that scenario may also be there. Talking about the adverse drug events, adverse drug events are defined as injuries that occur from the use of a drug, including harmful reactions and drug administration errors. The risk is twice with 5 to 7 medications and 4 times with more than 8 medications. And the effects on falls, cognitive impairment, hospitalization, we have already discussed earlier. This is responsible for 10% of all hospitalizations. The possibility of an adverse drug event should always be borne in mind whenever we evaluate a senior. So what happens is we just focus on the symptoms or on the ailments, and probably the thought never crosses our mind. Yes, could this be because of a drug? And if you spend a little time on reviewing the medication list of the patient, we find that there is a fair chance of the problems because of the drug. Factors for increased risk. So why should these elderly people be at risk because of polypharmacy? Because of frailty. Because of frailty, the metabolism changes and the disposition of the drugs changes. Because of coexisting medical problems. So there may be beneficial effect on one issue, but there may be adverse effect on the other. Then memory issues. Because of multiple medications, the person may not be able to take medication on the time, or maybe errors in dosing, duplication of medicines, or failure to take those medications. So having talked about the adverse drug events, what are the common and the main culprits? These are the blood thinners. They have been the worst, like anticoagulants like warfarin, aspirin. There is a risk of severe bleeding when used in patients without cardiovascular disease. So people come, and I find that they are being prescribed aspirin. Why? Blood thinner है, हार्ट की प्रॉब्लम नहीं होगी. लेकिन जो एविडेंस कहता है वो कहता है कि जिसको हार्ट की प्रॉब्लम नहीं है, एज अ प्राइमरी प्रिवेंशन इसको कहते हैं, उसमें यूज नहीं है. Why should we be subjected to unnecessary gastrointestinal hemorrhage or bleeding when there is no indication? Insulin and anti-diabetic agents increase risk of hypoglycemia. Now, a person who's having a long-standing diabetes, maybe senior age group, 80 plus, 85 plus, there is no use of controlling the blood sugar so tightly. I think you must be remembering, if you have attended, I've given a talk on diabetes in the elderly, and I mentioned the same thing. So these medicines, we have to see that there should be a reasonable control, and the patient should not be exposed to the risk of hypoglycemia. Non-steroidal anti-inflammatory drugs, for example, diclofenac or ibuprofen, they may lead to gastrointestinal bleeding, renal impairment, and heart failure in the seniors. Antihypertensive drugs. People comes blood pressure 140 by 90. I tell them it's okay. No, but my doctor says that it should be less than 140 or less than 130 by 80. But why? These aggressive control may lead cause dehydration if your patient is on a diuretic, for causing salt loss, sodium potassium imbalance, again compounding the already existing weakness, low blood pressure, leading on to dizziness and falls. Sedatives and psychotropic drugs, which act on the brain, they may cause altered mental status and falls, as we had mentioned earlier. Antibiotics, वायरल फीवर हुआ है, मैं तो एजिथ्रोमाइसिन लेकर आया हूँ और क्लैरिथ्रोमाइसिन खाकर आया हूँ, सेफिक्साइम या सेफ्टम या ऑगमेंटिन I've already taken. Why should they be taken when it's a viral infection that is not going to be affected by the antibiotics? There is no need to take. Why? Because it may lead to allergic reactions. You take an antibiotic and you develop an allergic reaction, now you start visiting a dermatologist or a physician. Then more antihistaminics or anti-allergic drugs, drowsiness. So again a cascade. And then somebody might say, oh, very severe reaction. You give steroids, and another bout of problem starts. So it's a vicious cycle. And it should be tackled right from the beginning. Ask yourself, does the patient require this medication? This is for the doctors actually. Diarrhea. People take medications and I tell them you were better had you not taken the medication. You would have got well much earlier. Decreased appetite, infection to theek ho gaya, but because of the antibiotics, that anorexia or the decreased appetite is still persisting. PPIs, for example, pantoprazole. If you keep on suppressing the acid inside the stomach, now acid is like a protective barrier. So you eliminate that acid because these are very powerful acid suppressants. You pose the patient the risk of pneumonia or the respiratory tract infections. Osteoporosis has also been described and dementia is also described with the users of these drugs. So we were talking about the prescribing cascade. So this is a very unpleasant but an interesting phenomenon. It occurs when the adverse effect is misdiagnosed as a new medical condition and treated with a potentially unnecessary drug. Like what I had mentioned in the beginning was that any new symptom on a patient on multiple drugs should be first accepted as resulting from the usage of that drug. Now, this misinterpretation is likely when the drug-induced symptoms are indistinguishable from illnesses that are common in older persons. For example, the patient is on antihypertensive drug and he develops dizziness or vertigo. Now, the importance is that we have to review, is there a possibility of blood pressure being low or some medicine which could cause a little bit of drowsiness or weakness or instability? If you see, don't analyze it, that the patient is having a dizziness, start another medication for dizziness. That may itself, because most of the medicines of dizziness, they act on the brain, the patient may still worsen. So this is important and this should be identified. The patient is then at the risk for developing additional adverse drug events related to the new and potentially unnecessary treatment. Let's see a few examples. Parkinson's is an ailment which affects the elderly population, and the initiation of anti-Parkinson therapy of symptoms arising from the use of drugs such as antipsychotics. Now, antipsychotic drugs, they have what is called extrapyramidal signs and symptoms, wherein the symptoms mimic Parkinson's. Now, you are using antipsychotics for a particular indication, or maybe perinom, metoclopramide, which also gives rise to abnormal movements, what is called dyskinesia. So, patient develops because of that. You start giving Parkinson's therapy for the side effect of the antipsychotic drug. The usage of anti-Parkinson drugs, that gives rise to new symptoms like low blood pressure and confusion. So this is again a cascade, prescription cascade. Many people, they come that slight cognitive impairment, which is many times normal and probably may not interfere with the day-to-day life. Very common drug called donepezil. It causes constipation and urinary retention. which are also common in the seniors population. Now, for urinary retention, you give oxybutynin, which causes diarrhea and urinary incontinence. So where do we land up into? You use a medicine which is probably of a doubtful benefit, and it causes certain symptoms. You give another medication for that, which has got a contrary side effects. Amlodipine. Amlodipine is an antihypertensive drug. It causes about swelling of the feet in about 10% of people. Now, if you do not realize that this is because of that medication, and addressing the use of the medication substitution with another medication or stopping that medication, it may be interpreted as a new condition. And instead of addressing the amlodipine as a culprit for the contributor to that swelling, you start treating with a diuretic. Now you use the diuretic, then again the problems of a diuresis, hypotension, dizziness, sodium potassium imbalance. Yes, swelling may decrease, but new sets of problems have started occurring. So that was about the adverse effects or adverse drug events in polypharmacy. The another important thing is drug interactions. Seniors are vulnerable to drug interactions because multiple chronic medical conditions require multiple drug therapies. So this is a central theme. Age, multiple conditions, multiple drugs, multiple interactions, side effects, and compromised quality of life. Examples are, as we have in our case study, the risk of bleeding with warfarin. Warfarin is an anticoagulant, a blood thinner, increased with co-administration of non-steroidal anti-inflammatory drugs like diclofenac and certain antidepressants, omeprazole, lipid-lowering agents, or there's a medicine called cortisone or amiodarone. Care must be taken in the elderly to review existing medications and consider potential drug interactions before adding a new medication. So, especially in the elderly, we have to be very careful whenever we write drugs. Revise in our mind. This is again, I'm calling for the doctor, but our population should be sensitized to this, that such things are very common and real before we add a new medication. So there are hordes of so many risks of polypharmacy. How to minimize the risks of polypharmacy? As I've been telling repeatedly, the essential principle is to continually reappraise the patient's medication regimen in the light of his or her current clinical status, the goals of care, what are our targets, what do we want to achieve, and the potential risk or benefit of each medication. This should be done at each OPD visit of the elderly and at the time of hospital discharge, as well as when the patient comes for follow-up after the hospital discharge. As a part of this, there should be a periodic evaluation of a drugs regimen, and the patient should be asked about all the drugs, not just the prescription drugs. Unless we specifically ask, आप और तो कुछ नहीं ले रहे हैं? हाँ, मैं ये भी लेता हूँ, मैं ये भी लेता हूँ, आपको पता चलेगा कितनी सारी दवाइयाँ ले रहे हैं. Over-the-counter drugs, herbs. लोग समझते हैं herbs हैं, उनका कुछ, they are all innocuous, harmless, but we don't know if they are made into a sort of a capsule or a dispensable drug. We don't know what additives are there, what excipients are there. Supplements. People ask me, can we take this for protein? Protein ke liye kya le? Should we take a protein supplement? We don't know. They may be certain, but they are not regulatory. They are not governed by regulatory authorities, and especially if the kidney function is compromised, they may have adverse effects. Periodic evaluation and assess the need for changes. These prescribing, will come to it shortly. And most important, always consider non-pharmacological approach, where the condition is amenable to lifestyle modification in lieu of pharmacotherapy. For example, discontinuation of antihypertensive medication has been possible in about 40% of patients with lifestyle alone. Talking of deprescribing, this is a new phenomenon. Medication deprescribing is a planned and supervised process of dose reduction or discontinuation of a medication that may be causing harm or no longer providing benefit to the patient. It results in improving the quality of life, reduces overall medication burden, and careful medication review and aggressive discontinuation can lead to a reduction in almost up to 39% of medications used, including reducing use of potentially inappropriate medications by around 30 to 60%, improve adherence to remaining medications. And the research has shown that if you start reducing these medicines, it doesn't result in any adverse events or any compromise in the patient's clinical condition. In fact, the patient starts feeling better. It reduces the risk of common geriatric issues like falls and cognitive impairment. And surprisingly, the reduced risk of hospitalization and death by 36% and 26% respectively. It was observed that the consideration of these principles led to discontinuation of 58% of the medication and no significant adverse effects were attributable to discontinuation. In fact, when the patients were interviewed, almost 80% of seniors would be open to stopping one or more of their prescribed medication, according to a 2023 poll by researchers at the University of Michigan. Medication de-intensification is part of a good clinical practice, since all medications are potentially harmful, cost money, and add complexity and potential for burden. Another vulnerable time is the transition of care. Why it happens is because of miscommunication about medications commonly occurs when a patient transitions. For example, a patient is in the hospital, admitted there, and then the patient shifts to hospital. So there's nobody to guide, because in the hospital, the patient was in a sicker state, more medications were there, the patient is stabilized and has been discharged for home. But the medicines which are there, probably they are of the same intensity which the person doesn't require. Diabetes medication, he may be on very high doses of insulin. And if the same dose is continued when the patient goes back home, he goes into hypoglycemia. So this can lead to inadvertent continuation of medication that should have been stopped either because they are causing documented harms or lack ongoing indications for use.
Doctor,
Now I'll be nearing the end of the talk.
yeah, thank you very
Moving
much,
to the
Doctor.
future technology, personalized medicine by pharmacogenomics, integrated electronic health records, telemedicine may help in adjusting medication, remote monitoring to provide vital data on vital signs, medication reconciliation, medication adherence to find out how it can be improved, and the long-term effects on different systems. So I'll conclude by saying that polypharmacy refers to the simultaneous use of multiple medications, often driven by an increase in chronic diseases and the availability of numerous medications. It can lead to adverse reactions, drug interactions, cognitive impairment, falls, diminished quality of life, non-adherence, and increased healthcare cost and medication errors. The interventions to minimize the risk of polypharmacy, thereby improving the quality of life of the seniors, includes medication reviews, deprescribing, that is the systematic process of discontinuing medications, patients' education, and shared decision-making between health providers, the family members, and the physicians and the patients. Thank you.
Thank you very much, Doctor. Thank you very much. I think a very detailed presentation, and I think you've explained so very well. We've received quite a few questions, but I must confess they are not on the subject that we have looked at today. So I'm not going to take them. I'm writing it down and I'm going to send it to Doctor later. Doctor, there's a few things on polypharmacy that is there. One is from Mr. Brijendra Kumar, because we just have 5 minutes left, so we will need to close early. He's 78, and his question is, any general rule for gap between taking medicine and capsules? He takes
In general?
Any general rule for a gap between taking tablets and capsules? He takes 9 medicines every day, 5 for heart and 3 for osteoarthritis, and 1 that is the nutrient.
See, now, if you take so many medications, I don't know the nature of the medicine, but if you take concurrently so many medications, we are not sure that one medication may be interfering with the absorption of the other medication. So the efficacy or the effectiveness might decrease. Like, for example, if I take some examples, like, for example, aspirin is given to patients who have already had a cardiac problem, and a statin, they usually are taken in the night. If the patient is having high blood pressure and if he's on a single drug, probably it would be, and in the morning, see, it is more important to control the morning blood pressure. So those medicines will be taken in the night. So somewhere it can be split. So if the 3 medicines out of 9 are shifted to the evening or night at bedtime or post dinner, the remaining 6 are left. So it definitely reduces the burden. One. And secondly, the preference should be to take fixed dose combinations. If there are 2 or 3 medications, if the physician considers it appropriate, he may use fixed drug combinations where the same are combined in a single pill. That increases the compliance.
Thank you. And one last question, Doctor. What about polypharmacy with, having allopathic medicines as well as Ayurvedic, homeopathic medicines? Is that because a lot of allopathic and a lot of Ayurvedic doctors or homeopathic doctors say that you continue to have your allopathic medicines, but also have this. Could there be a problem then?
See, this is a very confusing state of affairs as to now if somebody is taking Ayurvedic medicines, why should he take Ayurvedic medicines? That means if he is not satisfied with the allopathic system or medicine, then let him stop them. See, you have to give a green signal to one of them, because this cross-pathy is by our Medical Council of India or National Medical Commission is strongly discouraged, and in fact, it's an error. Now, for example, I will not name, but there are a lot of herbal medicines, and say 30 years back, virus hepatitis ho gaya, chalo ji, ye le lo, le 52 le lo. Now patients already take it, and many people used to write fearlessly on the prescription, but now we are not allowed. This is called cross-pathy. I don't think it is really beneficial for the patient, because you don't even know. Suppose if the Ayurvedic medicine is giving you benefit and is causing no harm, then why should you take allopathic medicine? Stop them.
Absolutely, Doctor. Doctor, thank you very much for your session. I think it's been a very detailed session. There are quite a few questions on diabetes, which I will send you because that's not the topic that we were discussing today. To all of you here, thank you for being here. To Dr. Gupta for this session. We've been talking about it, and I think polypharmacy is an issue that all seniors must be aware of. So if you have your medicines, please consult your doctor, speak to your doctor and say that these are the other medicines that you've been prescribed. And I'm sure the doctors would give you a fair counsel on what to have and what not to have and how to space it out. Thank you very much, all of you. We will be back again next Saturday. Next Saturday, that is August 19th, sorry. And for another session of Health Live at Seniors Today. And once again, Dr. Gupta, thank you for this amazing.
Thank you.